Yes, good afternoon, everybody, and welcome back to our conference session 2. I'm very pleased to meet you. My name is Zaza Tserteli, and I'm a senior advisor at the Royal Norwegian Ministry of Health and Care Services, and I'm also the program coordinator for the Barents program on new technologies, which is one of the initiators and coordinators of this event we are holding today. I'm very happy to see all of you now. And just before we start our presentations, just a small reminder that we keep the timing which we have for our presentations. And at the end of our session, we will have a question and answer session. So if you have some questions, please put it under the question and answer line, not the chat. So at the end, we will collect the questions and our panelists will try to answer on them. And because, as I have mentioned, our conference, one of the initiators of our conference was the Barents program, let me start my presentation and briefly present the program so that the audience and our friends know what are we talking about. The Barents program on new technologies and methods in healthcare in sparsely populated areas was launched in 2019 and will end till 2023. First of all, to say that there's a cooperation in the Barents Euro-Arctic region, which was launched in 1993 on 2 levels. One is on the level of intergovernmental Barents Euro-Arctic Council, and the second is interregional Barents Regional Council. The overall objective of the Barents cooperation is a sustainable development. The Barents cooperation has fostered a new sense of unity and closer contact among the people of the region, which is an excellent basis for the future project. The chairmanship rotates every 2nd year between Norway, Finland, Russia, and Sweden. And Norway took the Barents Euro-Arctic Council chairmanship from the Sweden in Barents Ministerial Session in Umeå in 2019. You see the members of the Barents Euro-Arctic Council. There are Denmark, Finland, Iceland, Norway, Russia, Sweden, and the European Commission. The chairmanship also is rotating, as I have mentioned. There is also International Barents Secretariat, which was established in Kirkenes. The Secretariat supports the multilateral activities within the Barents Euro-Arctic Council and the Barents Regional Council and secures the coherence and efficiency of the cooperation. There are 6 working groups under the Barents Euro-Arctic Cooperation, and one of them is a joint working group on health and social well-being. This group is closely cooperating with the Northern Dimension Partnership in Public Health and Social Well-being and the World Health Organization. Members of the joint working groups are Norway, Sweden, Finland, and Russia, both the central governmental level and the Barents regions in all 4 countries. The Indigenous People Working Group is represented by a member. The EU Commission, the World Health Organization, the Nordic Council of Ministers, and the Northern Dimension Partnership in Public Health and Social Well-being also take part in the work. The present program, the Framework Program on Health and Social Well-being, is regarded as a framework for the cooperation in health and related social issues, and is developed by the Joint Working Group based on the health and social situation in the Barents region. The main priority areas identified by the partner countries and regions are as following: the prevention and control of communicable diseases, improved health and increased access to healthcare in sparsely populated areas, improved environment for growth and development of children and youth, and prevention and control of non-communicable diseases. Priority areas 1, 2, and 3, the control of communicable diseases, improved health and growth in children. They are all presented by expert groups, programs, the Barents HIV and TB program, the Barents program of new technologies and methods for healthcare in sparsely populated areas, and the Barents program for children and youth at risk. The guiding principles of our programs are that we are all respecting the human rights and gender equality, sustainable developments through the Agenda of 2030, effective coordination in public health aspects, promotion of innovative approaches and technologies, and of course the health and well-being in all policies approach. As I have mentioned, the development of Barents program was started in 2018 and was adopted by the Ministerial Meeting in Oslo last year. Why we decided to launch the program? Despite the differences between the regions under the Barents cooperation, the key themes in healthcare in sparsely populated areas are more or less the same for all these regions. Access to healthcare facilities is the primary issue. Even in countries where the majority of the population lives in rural areas, the resources are concentrated in the cities. They all have difficulties with transport and communication, and they all face the challenges of shortage of doctors and other health professionals in these sparsely populated areas. Plus, we all faced the big demographic changes in our regions. As you can see from this map, most of our regions, the age group are more than 65 and 60 plus 65, and of course with increased age and increased chronic diseases, more and more needed to do in this work. So the aim of the program, which we have developed, is first to collect and exchange information and knowledge on best practices of cost-effective solutions to meet unmet healthcare needs in sparsely populated areas. And the second is the sharing of models or modules for introduction on health information technologies in different fields of the health and care systems, including exchanging personnel, training, and education. The program objectives are to improve the capacities of facilities and institutions, implement innovative e-health solutions and applications. Then second is to map and identify the best practices and innovative e-health solutions in our regions, which can be transferred and further developed. And also, of course, increase cooperation between the countries of the Barents region in the field of health and care population. The program may contribute also to development of modules for introduction of health technologies in different fields of healthcare system that could help healthcare clinicians and administrators, as well as policymakers and vendors, accelerate progress towards fulfilling the promotion of healthcare quality. The success of e-health solutions depends on the skills of clinicians and administrative staff. It is also important to include the patients in the process, using the e-services adapted to their individual characteristics and preferences. As a result, training both for the health professionals and the public are needed to ensure that e-health is successfully adopted and that health inequalities are reduced with the digitalization of our service. Currently, we are discussing some possible activities for our next year projects. And among those activities, we'll see that we'll have a training and education of health staff in the knowledge use and application of digital health, training for the patients, trying to document and sharing the best practices of the region, and then develop the modules for the introduction on e-health in the different fields of healthcare and system. How the program is working, we have established the steering committee for the program. The members from all the regions and countries are nominated one person to the steering committee. The chair of the steering committee is Oddvar Larsen from the Northern Norway Health Authority, and vice chairperson is Inga Vladimirovna Aniskova. She is a deputy minister of health of Murmansk region. We have the steering committee meeting twice per year, and between the meetings, the steering committee members are exchanging with emails and the different ideas, which then are shared within the regions. And one of the main activities, the first activity which our program and steering committee has implemented in 2019 was the assessment within Barents region. The results of this assessment I will present later after we will hear some presentations from our partner organizations and countries. So this was briefly what is all about our program, what kind of cooperation we have our program. And now I'm looking forward to listen to the presentations of our colleagues and friends from our region. And first of all, let me now give the floor to our first presenters. That's Mr. Bengt Andersson and Andreas Lundqvist. Bengt Andersson, he's a senior advisor, Nordic Welfare Center. He is responsible for combined Nordic efforts within the health and assist technologies. Placed at the Nordic Welfare Center, he has a professional and budgetary responsibility for all the projects and initiatives that is introduced within the welfare technology. As for Andreas Lundqvist, he is the head of unit at the Center for Rural Medicine in Storman, Sweden. He holds a Master of Science degree in Computing Science. And during his working years, he has been a strategist and project manager in national as well as international projects, often with a focus on telemedicine or healthcare at distance. His main area of interest is how to provide an accessible and equal healthcare regardless of geography or demographic conditions. Gentlemen, the floor is yours.
Thank you very much. As said, I'm Bengt Andersson from the Nordic Welfare Center as a senior advisor in the area of welfare technology or digital transformation in public sector. Maybe you give the word to present your as well, Andreas, so we can know that we can see and hear you.
Yeah, sure. My name is Andreas Lundqvist, and I'm the head of unit at the Center for Rural Medicine in Storuman. I hope you can see and hear me.
Yes, we can. Yeah, I'll start sharing the screen here. We have a presentation. There we go. I would like to start with thanking the organization for inviting us to do this presentation, the Norway and the County Council of Västerbotten. And our presentation is consisting of existing distance spanning solutions with a rural Arctic perspective. Let's see here, let's everything works. Yeah. What we're going to do is to present a proprietary project that's been going on from the Nordic Council of Ministers from 2018 called Healthcare and Care Through Distance Spanning Solutions, and also the 24 practical examples that we have from the Nordic region. You were with us from the morning. You heard Niklas Forsling from the Center of Rural Medicine do a brief presentation that we have done this, and we will go a little bit more deeper into what we've found, and some of these 24 practical examples we will explain a little bit more about. I just want to very briefly tell you what the Nordic Welfare Center is. It's an institution under the Nordic Council of Ministers. We have offices here in Stockholm, where I am right now, but also in Helsinki. And we are around 30 employees at the Nordic Welfare Center. And our main areas is the areas where the responsibility of public sector welfare is on municipal level. Andreas, tell us a little bit more about the Center for Rural Medicine.
Sure, I will. Actually, Niklas mentioned some of this in the morning session, but I'll briefly mention it again. We are a small research and development unit within Region Västerbotten. We have about 15 employees, and our main office is here in Storuman, where I am right now. And our employees are mainly based in the inland part of the northern parts of Sweden. And as Niklas mentioned earlier, we get our funding mainly through various projects. We can take the next slide. We try and describe what we do here at the Center for Rural Medicine in this picture, in this circle. And as I mentioned, we work with research and development in rural and remote areas. We think that if you are to have some kind of credibility when it comes to rural research, you should be based in a rural area, and that's one of the reasons that we are based in Storuman. One of the largest part of our organization deals with good quality local healthcare in rural and remote areas. And historically, that has meant that we have worked a lot with various forms of telemedicine or healthcare at a distance. We also work with Sami Health, our indigenous people, and we work with education and recruitment, as those two are key element when it comes to providing good quality healthcare in rural areas. So Bengt, back to you.
Yes. You just saw this slide. Dr. Cerelli showed you this slide. We think this is very important. One of the parts of this project we have been working on since 2018. An aging population affects the welfare model. This is from Nordregia, our sister organization in the Nordic cooperation, that provides these kind of maps where you can see the demographic vulnerability index indicated by group 65 plus. You can see that there's around 70% of the municipalities in the Nordic countries that are above this level. And there are some areas, and they are in the sparsely populated areas, that there are regions and municipalities that are over 30% of the population is over 65 years old. Of course, you can say that this is kind of a stigma to point out elderly people like this, but it stresses our welfare model when it comes to giving the support and the services in healthcare and social care. Also, what we know that the Center for Rural Medicine works with, as you said, Andreas, when it comes to recruitment or have the right staff in place in these areas, that is a very big challenge we have now. And then when we look for the upcoming 10 years, the challenge grows, and we have more, the vulnerability when it comes to this index increases. So what we have done in this project, Healthcare and Care through Distance Spanning Solutions, is that we have done a mapping of distance spanning solutions applied in the Nordic municipalities. We've also done a mapping of national methods and tools for implementation support. And the third and final block we're working on is through calls identify Nordic municipalities and regions for implementation and support of distance spanning solutions. And the first block, mapping of distance spanning solutions in the Nordics. You saw this slide earlier, Niklas Forsling showed it. It's a publication that came in Swedish in September 2019 and in January in English, where we have gathered these and present the 24 most interesting distance spanning solutions. We started up with doing this mapping and find a lot of distance spanning solutions. The criteria, that one of the highest criteria in coming into this publication and be one of the 24 most interesting distance spanning solutions is that it's not projects, it's not pilot projects. These are services that are in place. These are services that the population in these areas, they can have accessibility to these solutions. We have seen so many pilot projects and projects through the last 10-15 years in this area, and then we see that there is a really challenge when it comes to scaling up and going further up to the next step. And these 24 solutions that we have in this publication, they are all in place, and that's very, very important to mention. What we've done is to put them into 4 categories: remote treatment, remote monitoring, remote meetings, and new digital services also. And we are going to show you some examples of what these solutions are. And Andreas, we will start with something new you know a lot of. It's the virtual health rooms.
Yes, thank you, Bengt. The virtual health rooms is a concept for distance meetings plus monitoring and treatment. And you can switch over to the next slide directly, Bengt. This is something that we've actually worked with quite a lot at the Center for Rural Medicine, a concept that started with us. And what you see here on the picture is actually me pretending to be an assistant nurse examining a patient. And in the background, you can see a video conferencing screen with an expert on the other end trying to assess what we're seeing from the very highly the detailed camera, I should say. Next slide, please. This is a quote from one of our patients, one of the very first patients that came to the virtual health room. And she said something like this: "The first time I went to the virtual health room in Slussfors, I got to sit in a chair and we went through the initial tests. But you're diabetic," the assistant nurse told me. "What could I do apart from saying, thanks for telling me? That's life." We can take the next slide. So this concept actually has been developed independently in both Sweden, in the region of Västerbotten, and in northern parts of Denmark. And in the Swedish concepts, we have had the possibility of patients monitoring their own health with or without assistance. The result of these tests are transmitted directly to a database, and video consultations between patient and healthcare professionals can also be handled. In the Danish concept, they focused on distance consultations and with the added possibility of taking basic measurements. So we can take the next slide, Bengt. The other concept I wanted to talk to you about. There we are. Yeah, remote on-call support in rural areas. Remote on-call support from Kalix Hospital to the health centers in Övertorneå and Överkalix has been routine practice for 3 years now. During the evening, at night, and at weekends, there is no doctor at the health center in Övertorneå. So emergency cases, where appropriate, can be handled remotely via video conferencing. the patient is received by a nurse who will examine them and take the required samples. And the nurse has the possibility to take contact with the hospital, and if needed, a doctor can talk with face-to-face using a video system. The doctor can also use a remote-controlled camera, for example, to zoom in for closer examination. So, Bengt, back to you.
Yes, thank you. I will go on with giving some examples with more of a municipal responsibility. The first one is sort of divided with healthcare and care, where the region or the municipalities are responsible. It differs from our countries, of course, but it's electronic and automatic medicine dispensers. And when it comes to foremost elderly people with one or several chronic disease, we have challenges in how many medicines they eat, and also if they take the medicine at the right time, often combined with maybe some cognitive problems, dementia. This has been a very successful throughout scaling up and implemented through areas of the Nordic countries. To have these electronic and automatic medicine dispensers. You can program for 14 days, for 2 weeks, and out comes the medicine. You take a medicine at the right time and the right medicine at the right time. They are often, we see these areas that implemented this, they are often combined with forced video meetings. So ensure that the patient take the medicine. You have a short meeting to do this. And of course, this instead of driving around and giving people medicine when you're unsure if they take their medicine and then they take the medicine in right time. The second technology, the second distance spanning solutions I would like to present is localization technologies via, for example, GPS technology. There are a lot of safety alarms around the Nordic countries, but most safety alarms, they work just inside your home. There are not so many safety alarms that works outside your home when you're out on a walk. And this technology function as a safety alarm, but it has also localizations technology. And again, this is something that is very important for people to come out. And there is a quote from a Norwegian user of this that says, "A day without a walk is a bad day." It almost gets better if you say it in Norwegian. For those who know Scandinavian and Norwegian, to say that en dag utan en tur är en dårlig dag. So a day without a walk is a bad day. So feeling free and accessible to go outside is very important for your health. A third solution I would like to present is the digital night monitoring with cameras. It offers undisturbed sleep. We have a lot of night patrols driving around in the Nordic countries, just checking up that people are okay during nighttime. We have nurses driving around. Instead of doing all this driving around, and in fact, when they've done some reports on this, the staff drives around and sometimes wake up people instead of just making that they are sure safe in their bed. This is a solution that's been going on for 12 years and been more scaled up now around a lot of municipalities in the Nordic countries. We also see other kind of technologies here, like sensors, of course, and heat cameras. This is an example of 5 of these 24 solutions. So go in, you will be present this, you will have accessibility to this presentation, then you can go into the links and download the report with the 24 solutions, where you can look in further to the 19 that we not have presented here. We also like to mention that we've done mapping on methods and tools for implementation support. I think Niklas mentioned this earlier today as well. All 5 Nordic countries have national visions and strategies for e-health and welfare technology. And we heard Maja Fjestad talking about Sweden going to be world number 1 in 2025 and the strategy for that. But when it comes down to tools and strategies on local level, we don't find so much when it comes to the regional's responsibility. And the best thing we found, and we really promote, is, as we earlier said, is the Vägkart för tjänsteinnovation innovation, or roadmap for service innovation, the Norwegian roadmap that we have translated to all languages, and that you can download and find. We think this is the best roadmap to use, and one of the two, there are 6 steps in this roadmap, and the first 2 ones we have identified as very important. It's anchoring and insight, and we heard earlier from the Russian presentation just before the break that they took the doctors in the room, the virtual room, to really test how to do this. But we see that anchoring and insight is crucial to be successful to do this. It's not so much about the technology, it's more about the organization and getting these things in place to really implement this in a good way. Just briefly on block 3, we have through calls identifying Nordic municipalities and regions for implementation support of distance spanning solutions, and we have a lot of regions and municipalities is now working. They use the roadmap for service innovation. That's a criteria from us for work for getting funding for these projects, that they have to work with a Norwegian roadmap for service innovation. You will recognize the next slide, because again, we think this is really crucial when it comes to scaling up. We see example of regions and municipalities that have come very far when it comes to implementing several of these distance spanning solutions. They get a lot of data they have to handle, and how to do this is really the bottleneck. To have a response service platform, and what do you need, what kind of information do you need to handle in the organization, and what could go back to the client, the patient themselves, to interact on the data they have and that they use. And we can see that the region that had come furthest in this area is Eksote in Finland. They have really integrated healthcare and social care. They also use data lakes and response services to do this in the best way, and also trying to use this data to work preventive in the best ways. This is something that we like to finish up with. We see, as also earlier heard, that wearables is the future of integrated healthcare and care, and you have it on your wrist. Some of the examples we mentioned here, for example, the GPS tracking device and also the night camera, could be replaced by these mainstream products. Just we need to integrate them in a very good way to be a part of the future integrated healthcare and care. Okay, Andreas, do you have anything more to conclude, add?
No, I think you made a good point there, Bengt. So I'm quite happy with your finish there. So thank you.
Okay. Well, then I say thank you. Then we say thank you.
Thank you very much for very, very interesting presentation. And as I know, the next year you will have like a summing up conference. So we're looking forward to be there also and to listen more about and learn more. And I think also we can continue more closely collaborate within this Barents cooperation on this very interesting topic and fields. Thank you very much.
Absolutely. Thank you.
Thank you.
Thank you. And now I'm giving floor to our next presenter, Sture Pettersen. Sture is currently manager for eHealth in Finnmark Hospital Trust. His main focus is on strategic management of ICTs, telemedicine, digitalization, and innovation. He has since 1994 been working at the Norwegian Center of Integrated Care and Telemedicine, University Hospital of North Norway. He has been director for innovation and implementation and manager for Tromsø Telemedicine Laboratory, which is a consortium of industry and research institutions hosted by NST and one of the Norway centers for research-based innovation. He has a master's in science in engineering and MBA in health management and additional credits in project management. Sture, the floor is yours.
Thank you for the kind introduction. I just had to start to say that this last 10 months has been really a crash course in digital transformation. I've never experienced over my lifetime so many things happening and at the same time, just to cope with the COVID-19 situation. And that's what I want to talk about. I'm not going to talk about all the projects that we're doing, but stick to what we have done in this special situation. First of all, before the pandemic, we had a quite good situation in northern Norway. We have one shared electronic medical record system, all in one database, and we also share all the radiology and pathology images in one digital medical archive system. We have, for many years now, had the common electronic requisition and report system, and everything is communicated over a closed secure network. And from 2015, every patient have access to their own medical record through the national health portal. So we had a good starting point when the pandemic arrived. And just to give a couple of examples that I haven't worked very much with, but was important, is that we very rapidly, during just a few weeks, established a system for risk stratification of all patients at the hospitals, so that we can easily see who was in a situation where this could lead to a more severe situation. And that we could do that because we had one system, all the hospitals together, and also with two of the other regions in Norway. We also quite soon got a system in place so that patients could see their results on COVID-19, the lab reports over the net at home. So we didn't put too much burden on people answering questions about lab results. So that was just two examples of how I feel we was quite prepared for the situation, but still we had to do a lot of other things. We had to postpone some of our activities and prioritize other activities. But our goal has always been the same. We want the clinicians to use the medical record system as a tool also for enabling distance spanning health. And we do this by including primary care and the patients, and try to include them in all stages of the treatment. For example, if there is an acute situation, the patient can call 113, and they can start a video. The doctor on call can start a video session at once. You can also give advice to municipalities about the situation. You can monitor patients outside the hospital, and we have a very good pre-hospital support as well. But this is the way we're doing is not to put more work on the other. It's more to cooperate during the patient pathway and make it much more safe and secure by integrated into the system that the clinicians already are using. And as I said, the patients all use the national portal for accessing information and giving away information as well. So here's what we did from March to now. First of all, we did use Skype for Business quite extensively when it came to patient consultation, but we needed a simpler system and also a more secure system. So in just a few weeks, we started using a new video conferencing system, which is much easier for the patient. They receive an SMS and they click on the link and they are up and running. So this was a huge step forward. At the same time, we integrated the video into the medical record system so that the clinician just could start it as just the same way as the patient came in the door for an outpatient consultation. And as I said, this is simpler, and the patient can change their appointment if they want through the national portal, and it's been quite a good success, this new system. We was also very late compared to the other regions in Norway with a secure messaging between the general practitioner and the hospital, which we soon got in place. And we also have started using Schema's digital assessment, where you can score, you can make reports that also integrate it into the record system. Same thing actually with rheumatology patients. There is another system. So there is a lot of good stuff that has been going on. I should also mention maybe that Nordlandssykehuset, one of the hospitals, implemented a Finnish system, Medanet, so that they can get the early warning scores. That's, let's say, pulse oximetry, blood saturation, etc. They can get that directly into the medical record system via an app that they move around that they use in the hospital. And we are now also establishing a kind of e-health rooms, several places around the region for patients who have trouble to do consultations at home. So there's a lot of things going on. And if you look at the results, you can see there's a big top in March, April when it comes to video conferencing with patients. It's later gone down, but it's much higher than, it's 4 times as high as it was in 1919. The region has set a goal that we should use remote consultations. At least 30% of the outpatient consultations should be done by video or other kinds of tools. We are not there yet, but we are moving in the right direction. If you look at the statistic here, you can see that it is mainly mental health and addiction and substitution treatment that is the highest volume. But also in diabetes and rheumatology and some other areas, there's a quite good numbers as well. But we're still struggling with increasing the number of consultation in the somatic areas. I think there is a lot of culture there and tradition that they are much more used to seeing the patient. And there's always a professional decision to decide if this is good enough for the consultation for the patient, that they get enough information. So we're still working on that, having meetings with all the departments and try to give better, to have more use in the somatic areas of medicine. Can also just mention that what we also have a challenge with is also the aging population. And as been said earlier, the aging population have also several chronic conditions. Around 5% of these patients, or overall patient at the hospital, uses around 50% of the resources. So to have a better system to follow up those patients together with the primary care level, and at least, and not at least, the patient itself is really, really important. And to do this, we now need the possibility to share documents better, to share data better, and to have a system that we can plan what it's going to do with the patient, where the patient is the main voice in what's going to happen. So we're looking forward to having a more patient-oriented system where we include the patient much stronger, more preventive medicine. And of course, this has to be done in an interdisciplinary setting where different kinds of professionals can join in and work together with the patient. So that was my thank you.
Thank you very much, Stu. Thank you very much for the very interesting presentation. And as you have mentioned, really a lot is going on in our regions, and especially during the COVID-19, and more perspectives are opening. So let's see how this will all develop and what we'll have in 2021. Thanks a lot. Thank you. Now I'm going to the next presenter, Ms. Katarzyna Wikström. Katarzyna is a registered nurse and a master in mathematical statistics. For the past 15 years, she worked in the different executive leadership positions, and for the last 4 years is a manager of the 3 healthcare centers and the municipal director for 7 years. Her current position is a project manager for the project Good Quality Local Healthcare in South Lapland. The aim of the project is to create organizational models and methods of work to reorganize the healthcare and care systems in order to facilitate collaboration and improve healthcare and care for inhabitants of South Lapland area. Katarzyna, the floor is yours.
Thank you very much. Thank you very much for the introduction. My name is Katarzyna Wikström, and first of all, thank you for the opportunity to present our work in South Lapland. Let me just see here. The outline of the presentation, sorry about that. The outline of the presentation is shortly to tell you about South Lapland. Give you a little bit about the project Good Quality Local Healthcare Reform, and also give you also an insight on the current work focusing on the e-health technology in municipalities in the region of Västerbotten. So first of all, South Lapland and the region of Västerbotten, located in the north of Sweden. As you may know, Sweden is divided into 290 municipalities, 21 regional councils. And region of Västerbotten is one of them, and South Lapland is containing 7 municipalities. The healthcare in Sweden is divided. The health centers and hospitals are run by the regions, and the municipalities are responsible for the care for the elderly and in their home and in special accommodations. But a little bit more about the South Lapland. Population density is around 1 to 2 inhabitants per square kilometer, so it's very rural. For a very long period of time, there have been a population decline for the last 40 years, and we have a lot of challenges with difficulties with recruiting staff, lacking physician, nurses, and other health professionals. We also have a demographical challenge. The number of elderly people is increasing in South Lapland, and as you can see here, the ratio of population above 85 years old is increasing in the municipalities compared to the rest of Sweden, where it's more stable. So a little bit challenges here. Now I move on to tell you more about the Good Quality Local Healthcare Reform in Sweden. In short, during the last couple of years, there have been several inquiries from the government regarding national strategies for developing the future healthcare and social care in Sweden. And the reports that are made, they state that resources are limited, and it is very important to make healthcare interventions as effective as possible. And also another conclusion is that if we want to maintain or increase the quality with current demographic challenges, and keep the costs under control, we need to do it differently compared to how we organize the healthcare today. And also what it stated is that that we need to switch focus from from having focus on the organization to more have focus on being a person and relationship oriented, from being reactive to more proactive and health promoting. Also from viewing the patient as passive receiver of healthcare to more look at it as an active co-creator. And also instead of looking at isolated healthcare more and care interventions to focus on the care receivers. So this is what is stated in the reports and what we want to focus on in Sweden. So looking at the South Lapland with the challenges that we have, how do we do this? How do we do it with 7 municipalities and the regional health? So first of all, we looked at the organization and we had a dialogue in the municipalities and found the first step was to set and find out more about the long-term goals in every municipality and also have a dialogue with the politicians and the decision makers, where they see the municipality right now and what to do in the future. We also had a workshop with managers and decision makers. And this was very important to confirm that we want what we want to do in the future and how if we share the focus on what we want to accomplish. And also we had and have ongoing dialogue with the co-workers and inhabitants. So from all that, we saw that we have 4 focus areas: the digital transformation, the talent management, collaboration, participation, the patients, and public health. And this is what we said that we want to do together. And to start, we focused on 2 projects. One is to increase competence regarding digital transformation and digital leadership among staff and decision makers. And another one is increased number of digital services in municipalities and regional healthcare. And the first project is actually a collaboration between 15 municipalities, and the second one is actually 8 municipalities, 7 in South Lapland and 1 more. And I will tell you a little bit about the last project, this one, increased number of digital services in municipalities and the regional healthcare. What we wanted to do in this project is to look at the Norwegian strategy or the Norwegian roadmap or guideline, how to introduce digital services in municipalities. It has worked out well in Norway, and we wanted to look at it and put it into South Lapland context and develop a strategy for South Lapland. From that, we wanted to actually introduce at least 2 digital services in municipality. And we also wanted to include home monitoring devices for at least 100 patients. And after that, we want to analyze the synergies and develop a joint structure for healthcare and care. And this is the last step, and it will be done in March 2023. So the project is just started. So the next step, of course, we have several other projects starting 2021, besides from the one I told you about right now. We will continue to have the dialogue with co-workers and inhabitants, also politicians and decision makers. And we will focus on the 4 focus areas. We also want to challenge current policies and way of work in order to develop new ones. And this is how we think we can meet the intentions of the national strategy for good quality and local healthcare. And we see that what we need to do have focus on to collaborate and to co-create between organizations. So in summary, this was very short about South Lapland and the healthcare and social care in general, and the reform good quality and local healthcare, and also how we are tackling it in South Lapland and how we can contribute to better healthcare in rural areas. So thank you very much for listening.
Thank you very much, Katarzyna. Thank you very much for this very interesting presentation. I think there will be some questions at the end, but I saw also that you have a good plans for 2021, and good luck with that, and good luck with your work with the politicians and all the
Thank you.
co-workers in the municipality
you.
level. Thank you very much. And now I'm going to our next speaker from Murmansk, Inga Vladimirovna Aniskova. Inga Vladimirovna graduated from the State Medical Academy of Tyumen with a degree in general medicine. And in 2001, she graduated from the school with the title of Candidate of the Medical Science. In 2008, Inga Vladimirovna finished the Russian Academy of National Economy and Public Administration under the President of the Russian Federation with the qualification of manager. And since 2002, she is working in the Murmansk in the different fields of the Health Committee, which was later transformed into the Ministry of Health of the Murmansk region. And she was first the head of the Department for the Organization of Medical Care. And at the present, Inga Vladimirovna Aniskova is the first Deputy Minister of the Health of the Murmansk region. I'm very pleased to give the floor to Inga Vladimirovna. Inga Vladimirovna, the floor is yours.
Добрый день, уважаемые коллеги. В первую очередь мне хотелось бы поблагодарить за уникальную возможность участвовать в таком интересном и уникальном образовательном, наверное, для нас мероприятии. Сейчас я очень коротко постараюсь рассказать, как мы идем по пути развития информационных технологий в здравоохранении, какие находки, какие маленькие для нас победы получилось достичь в этом году. Наша Мурманская область небольшая. У нас проживает около 740 тысяч человек. Особенностью является небольшой процент сельского населения, всего лишь около 8% населения у нас проживает в сельской местности. Но учитывая, что расстояние между областным центром и самыми отдаленными точками нашей области превышает 550 километров, и зачастую можно туда добраться только с помощью санитарного автотранспорта. И наличие наших, конечно, проблемы с кадровым обеспечением первичного звена, у нас все предпосылки сложились для развития именно медицинских информационных систем и их использования в очень широком смысле слова. У нас 35 медицинских организаций, около 170 отдельных структурных подразделений, которые должны быть связаны в одно и воедино. Вообще в России медицинские информационные системы очень стремительно развиваются. Мы, может быть, не достигли тех результатов, которые демонстрируют у нас наши коллеги из многих европейских стран. Но Мурманская область делает свой небольшой вклад именно в развитие единой государственной информационной системы. Для этого у нас все есть. Есть точки доступа, около 140 точек доступа в 30 медицинских организациях. У нас есть и каналы связи оптоволоконные, и средства защиты на базе VIPNet. Достаточное количество серверного оборудования и автоматизированных рабочих мест. Главное и приоритетное для нас направление, оно и действительно для нас очень важно, это развитие и формирование интегрированной электронной карты пациентов Мурманской области. Сейчас мы уже умеем и можем собирать информацию на пациента любой медицинской организации, иметь доступ к этой информации, и диагнозы, и результаты обследования, и консультативные заключения, и сведения об операциях, аллергических реакциях, и много дополнительной информации. Все, для нас очень важно именно документирование и сохранение информации и предоставление равного доступа к этой информации всех медицинских работников. Автоматизированы у нас уже система лекарственного обеспечения. Выстроены единые технологические процессы от выписывания рецепта до его получения. 34 медицинских организаций, более 40 аптечных пунктов у нас подключены к системе лекарственного обеспечения. И ежегодно мы выписываем более 70 тысячам пациентов, более 400 тысяч рецептов. Система управления очередями – это одна из медицинских информационных систем, которая у нас используется. Это не только возможность вести единую региональную очередь пациентов на госпитализацию, консультативный прием, диагностические исследования. И для нас это еще возможность провести анализ потребления тех или иных видов помощи, насколько они востребованы у медицинских работников, у нашего населения, и проводить анализ контроля срока оказания медицинской помощи, сколько у нас, как длительно пациент ждет тех или иных исследований. Благодаря вот этой системе управления очередями у нас ежегодно, в прошлом году выдано более 140 тысяч направлений на получение медицинских услуг. За 9 месяцев больше 100 тысяч этих направлений. Работали мы для развития и использования наших колл-центров для общения с пациентом. И если в прошлые годы главный вектор нашего развития был дать обратную связь пациентов, то есть мы внедряли роботизированные обзвоны пациентов, напоминали о приеме, подтверждении визитов. Главная наша задача была скорректировать запись и сделать ее более доступным за счет исключения недоходов пациентов, то во время распространения новой коронавирусной инфекции для нас наши инструменты нам помогают оценить востребованность со стороны пациента общения с медицинским работником. И мы удачно сейчас используем и разработанные стандартные речевые модули, опросники. Мы анализируем записи телефонных звонков и анализируем эффективность работы операторов, чтобы предусмотреть увеличение возможностей этих телефонных линий. Телемедицинская система существует в Мурманской области. Она представлена из 19 телемедицинских комплексов и собрана из 5 консультативных центров областного уровня и 8 консультативных центров межрайонного уровня. Если наше, наверное, направление развития телемедицинских технологий до 2020 года больше акцентировалось на взаимоотношении между медицинскими работниками. Это получение консультации по типу врач-врач, врач-медицинская сестра. В настоящее время мы видим, насколько увеличилась востребованность таких консультаций. Если в 2019 году их было более 3000, то сейчас аналогичный период, за прошедший период 2020 года таких консультаций уже больше 10 500. То есть почти в 3 раза у нас рост этих консультаций. Конечно, результаты представлены на слайде. В первую очередь это рекомендации по ведению пациентов, это и перевод из учреждения в учреждение. Здесь мы имеем в виду стационарные учреждения, определение необходимости очного осмотра или госпитализации пациентов. Говоря о телемедицинской системе, мы говорим о том, что у нас построена система сейчас определения рисков тяжести пациентов, находящихся на лечении в стационарах с ковид-инфекцией, и возможность вот такой вот онлайн быстрой или отсроченной консультации в учреждениях более высокого уровня, то есть в областных центрах. К этому нас помогает нам осуществлять наши планы и развитие Центрального архива медицинских изображений. В нашем регионе 56 единиц оборудования уже подключены в единую систему. Это и компьютерные томографы, и магнитно-резонансные томографы, рентгены и маммографические аппараты подключены в единую систему. уже в нашем хранилище цифровых изображений содержатся сведения около 798 тысяч проведенных исследований. И для нас это не просто хранилище медицинских документов, это возможность оперативного доступа к этим исследованиям всех специалистов, формирования аналитических отчетов и получения консультации коллеги более высокого уровня для оперативности постановки диагнозов, возможность применять в данной схеме и технологии искусственного интеллекта. Сегодня мы сейчас работаем над выстраиванием данной системы подключения всего комплекса лабораторного оборудования и центрального архива лабораторных исследований. Что нам принес опыт ведения пациентов с ковид? Для нас это первый опыт. Насколько он удачный, мы будем дальше судить, мы будем развивать данное направление. Но мы попробовали организацию мобильного мониторинга состояния пациентов именно с ковид, которые находятся у нас на лечении на дому. Таких пациентов у нас много, более 5000 людей одномоментно у нас лечится вне госпитальной базы. Наш мониторинг состояния здоровья – это некое приложение в телефоне, которое позволяет пациенту заполнять ежедневно стандартизированную анкету, которая включает в себя это субъективная оценка самочувствия пациента по определенным заданным параметрам, это показатели гемодинамики, концентрации кислорода в крови. Автоматизированная система позволяет нам распределить пациентов, заполняющих этот мониторинг, на 3 контрольные группы. Красная зона, лица, попадающие пациенты в красную зону, говорит нам о сигнале для медицинского работника. Это необходим срочный очный осмотр врача для определения тактики ведения пациента. Возможно, скорее всего, вопрос идет о госпитализации на госпитальную базу. Желтая зона, то есть пациенты, попадающие в желтую зону, подлежат или дистанционному наблюдению медицинским работникам посредством телемедицинских или других способов дистанционного контроля, и визит или осмотр медицинского работника может быть отсрочен. И зеленая зона – это те пациенты, которые могут продолжать самонаблюдение. В развитии мы сейчас разрабатываем и работаем над приложением «Мобильный кабинет пациента». Это то направление, над которым работают многие наши коллеги и в России, и не только в России. Это сервис для гражданина, для нас это новый сервис для гражданина, который позволит не только заполнять анкеты для дистанционного мониторинга состояния здоровья, он может позволить просматривать результаты своих лабораторных исследований, сделать доступный доступ к ним, просматривать выписанные рецепты, данные своей электронной медицинской карты. И туда может быть встроена информация образовательного характера для пациентов, включая необходимую информацию справочного характера или инструкции по применению лекарственных препаратов. И наша цель подстроить еще передачу информации с носимых устройств, да, то есть над этим мы сейчас очень плотно работаем. Мне хотелось бы еще раз поблагодарить организаторов конференции за возможность не только поучаствовать, но ознакомиться с уникальным и интересным опытом наших коллег по цифровизации, по развитию различных сервисов для граждан и возможностей для медицинских работников. Глаза у нас горят. И я надеюсь, что мы благодаря нашему сотрудничеству можем предложить через короткое время действительно очень нужные и удобные сервисы для пациентов и дополнительные возможности для нашей медицины. Спасибо большое.
Спасибо большое. Thank you very much. Inga Vladimirovna was very interesting presentation, especially related to the mobile health monitoring of COVID-19 patients. So maybe after these sessions, we will have some more questions related to this, but thank you very much. And now I'm going to the next speaker, Jarmo Reponen. Jarmo is a radiologist and professor of practice in health information systems at Research Group of Medical Imaging, Physics and Technology at the Faculty of Medicine of University of Oulu. Parallel to a long experience as a chief radiologist, he has more than 30 years of experience in implementing and teaching the digital systems in healthcare environment. His group co-developed the first in the world mobile medical app for smartphones already in 1998. He was also responsible for the development of one of the first comprehensive cloud-based electronic health record system to a university hospital level since 1996, and he has widely contributed to the national health information system development in Finland. We are very glad to see you, Jarmo, here, and the floor is yours.
So thank you very much. It's a pleasure to be here. Thank you for the invitation. This afternoon, I will discuss with you about the digital solutions in health in Finland and especially the national experience during the COVID-19 epidemic. And this will be the contents of my presentation. I will first discuss the digital back office in Finland, what kind of systems we have in our digital infrastructure nationally available already before the epidemic. And then secondly, I will discuss the COVID-19 response, what was the general cause of the epidemic, and what kind of mobile corona apps we have been using and what kind of information resources they have been available for the citizens. And then the third part is how physician consultations changed during the COVID-19 epidemic. And the image there on the right-hand side is just a reminder that mobile apps are nothing new, as it was said in the presentation introduction. So already 20 years ago, we have one installed here in Oulu. But first, the digital back office. And in Finland, in the local level, according to the studies we have made in our institutions, already in 2007, all the public healthcare institutions were storing all the new information in digital format, in electronic patient records, and in picture archiving and communication and laboratory systems. And then what we are very proud of is our National Health Information Exchange System, the Kanta systems, which contains archiving system for all the medical records in the country, e-prescription services, also services for the ordinary citizens so that they can have a look at the medical information there. And also it connects the pharmacies and the whole social care institutions. So it's actually a national lifelong medical record and in the future also a social care record. And this year we are having the 10-year anniversary of the Kanta system, and the citizens in Finland, they are really using the system. Every month we have now about 2 million different sign-ins to the system, and a little bit less than 1 million different people are accessing the medical data from the system every month. And about half of the population in Finland has cumulatively used their own MyKanta pages to look at their medical information there. And the Finnish citizens are very active users of online health solutions. So according to the European study, Eurobarometer study, the people in Finland and Estonia are the most active. 50% of those people in these countries are already using e-health services already before the COVID-19 epidemic. So what was the response then during the epidemic, how people learned to use new mobile apps and information resources? This figure here shows the general cause of the epidemic in our country. So we have had those two waves, the first wave and the second wave, as most of the countries. And the blue ones are those who were in hospital care every day. So during the spring months in March, the largest figures were around 250 people were in hospital care. The red ones are those who were in intensive care, and the yellow ones are those who died of the infection. So even though the second wave is now on, so there are not so many people in hospitalized care at the moment in Finland. And the Finnish health authorities, they have this hybrid strategy. It's trace, isolate, and care. And we have a couple of apps which have been helping us. Then the first app was in this isolate and care phase of this strategy. And it's called Oma Olo COVID-19 Symptom Checkup app, which you can get access through your mobile phone or through the web pages. And there you can assess your symptoms. And if the app gives you advice, you can then book for your corona test from the local health authorities. And then you can also send your information, the symptoms that you just have told to the app over a secure channel to the emergency department if you are needed to be referred to emergency services. And the app was launched very quickly at the beginning of the first wave of the epidemic. And of those people who have been using the app, 88% who have done the questionnaires, they have been assessed symptomatic, and 15% of those users have been directly then to the healthcare emergency services with the help of that app. And actually the amount of what was the percentage, how many have been sent to the emergency department, it has been quite stable throughout the months. Then the second app we are using nationally is in this trace or isolate phases, and that's the Koronavilkku. That's the official Finland's coronavirus warning app. It gives you information if you have been in vicinity or close to another person who has been infected by the virus. And the app was launched at the end of August this year, and already during that day, there have been 1 million downloads from the app stores. And then until the end of October, 2.5 million Finnish citizens have been downloaded this app to their mobile phones. So relative to the population size, Koronavilkku is one of the most downloaded coronavirus applications in the world at the moment. Then how people are using the services. These are figures about the usage of the national MyKanta pages, so people's access to their own medical data. During the spring months, you didn't see much difference, but then now during the autumn months, people have been learning to use the national web pages, and they are now looking their test results mostly directly from through these MyKanta pages applications. So the healthcare personnel doesn't anymore telephone to the people in case of negative results. What happened to the physician consultations? The other ways of remote consultations like telephone or e-consultations have been decreasing, but real-time remote consultations have been steadily increasing during the coronavirus epidemic in the public healthcare. So also in the public healthcare, the remote real-time consultation is now the most often used real-time connection with the citizen between the healthcare service providers and citizens. The private sector has been doing their part too. They are supplying a lot of information through their web pages. So this is from one of the major private healthcare provider in Finland, the Mehiläinen Ltd. They are having real-time maps where they have been performing corona tests, and they also show with red dots where the tests have been positive. Similar type of information is available from another major private service provider, Terveystalo. There are also these maps and figures available through their web pages. And they have been even more active in remote consultations than the public sector. So already during the first wave, in the springtime, you saw the increase in their distant consultations, and now they are steadily having a lot of distant consultation in this autumn season. So actually this was my short glimpse to the situation in Finland. Thank you for listening.
Thank you, Jarmo. Thank you very much for very interesting presentation and very interesting experiences from Finland. I think we'll come back to the question and answer session to this, especially the usage of the mobile apps, because it was not the same in many countries. So it will be interesting to hear a bit more about the Finnish experience from you. Thank you very much. And now it's again my turn. I need now to present briefly the results of the assessment we have mentioned already to you. That was done through our program. So I'll share now the screen and just a second. And 1 second. Sorry, 1 second. Yes. Yeah, this is how it is during the e-health. For some reasons, oops, now here we are. Yes. So let me share now with you the presentation about the assessment, which I have mentioned. The name of the assessment was Barometer of the Digital Transformation for the Citizens with a Chronic Disease. This assessment is based on the questionnaire developed by the steering committee for the program and aimed to assess the trends and challenges our regions are facing in the field of the digital health. Plus, the decision about the possible future projects will be also discussed based on the assessment. The idea to have this assessment was born in November last year when we were free of the COVID. So, and the first plan was to assess the situation in our sparsely populated regions. However, when the pandemic started, we have added some questions and tried to see how the pandemic has affected the usage of the digital solutions. You see now the regions which were covered by assessment. So all the regions of our cooperation has participated. A small exception was the Norrbotten region, as within the region, a restructuring of the entire healthcare system and the administration was underway. So they were busy with this transition and they're not able to give us the full answers to the questionnaire. Before starting the assessment, of course, we needed to decide what kind of term we will use as a digital health, because it was discussed widely and yet agreed upon the definition of digital health remains elusive. There are a variety of terms and concepts which are used interchangeably, and they're referring sometimes to the e-health, which is mobile health, or the e-health, technology and digital applications to assist patients in their health and virtual care. And finally, the World Health Organization definition of digital health is a broad umbrella term encompassing e-health, as well as emerging areas such as the use of advanced computing science in the big data, genomics, and artificial intelligence. So the term in which we have decided to use in our application, the definition was that digital health involves a broad variety of technologies and tactics to deliver virtual health and medical care and education services outside of the traditional healthcare facilities. It allows long-distance delivery and facilitation of clinical and non-clinical applications to enhance care and education delivery, administration, and research. So what was important that we included here both the clinical and non-clinical applications to the end. Our first question was what type of digital solutions we are providing and planning to provide. As you can see, the mobile health was on the top, followed by administrative meetings and trainings, which this refers to all kinds of the meetings both between the professions and between citizens and professionals. Then it was providing training and medical staff education, remote patient monitoring, which refers to sensor cameras, reminders, and data collection, video consultations, and patient education. But video consultations has not been used frequently before the COVID-19. There was a capability, but there was not so much use, and now it's changed dramatically. What kind of conditions the health professionals were targeting with the digital solutions? Not surprisingly, the chronic diseases has been a key for the distance for which has been used before the COVID-19, for the medication therapy and preventive measures. Mental health services were not used much before the COVID-19. We had good examples of digital solutions, for example, the program like MyPath, which is a digital service portal where patients can get care and support at any time. There are self-care programs for all citizens and digital care paths dedicated to specific disease groups. There are 15 digital care pathways for all the different patient groups, and about 20 is under process. That is implemented, for example, by Oulu University. Or the pulse oximetry, measurement of blood pressure, blood sugar, and ECG recording, which was carried out like a pilot project in the Nenets Autonomous Oblast. Since 2019, the Telemedicine Competence Center for Remote Monitoring and Counseling of Patients with Severe and Urgent Conditions has been organized on the basis of Arkhangelsk Regional Clinical Hospital. Based on the results of the telemedicine consultations, remote monitoring of severe patients is carried out. The specialists of this hospital resolve issues of the need for the medical evacuation to level 3 medical organizations, which are regional, specialized, and multidisciplinary healthcare institutions. As part of the implementation of the measures of the federal project Information Infrastructure of the National Program Digital Economy of the Russian Federation, the federal obstetric points, FAPs, were also connected to the internet. And in 2019, more than 61 FAPs were connected through this in the Arkhangelsk region. We also asked what kind of policies were having countries before the COVID-19 period. And for example, in the Russian Federation, there are special orders of the Ministry of Health from 2018 on approval of the procedures for organizing and providing medical care using telemedicine technologies. And there is a special order from 2018 approving the requirements for state information systems. And finally, all the regions are running the big federal project, creation of unified digital circuits in healthcare basis of the unified state health information systems of the national project of healthcare. As for the Nordic countries, as it was mentioned already, the Finland has an e-health and social strategies, which is by 2020. Norway has a policy on e-health, including strategy and action plan for e-health by 2017-22, and also has a national tools for implementation of distance spending solutions with the main focus on municipal responsibility. And Sweden, as it was many times mentioned already, has a special strategy vision for e-health 2025. But then COVID-19 started, and there were like jokes, what has changed during the COVID-19, why we all transformed our companies to the digital transformation. And as you see, there was like an anecdotal, it's not the CEO or STO, it's the COVID-19 who led the digital transformation in our companies. So what we see during the COVID-19, based on our assessment, the chronic diseases was the main area, but now it shifts to the clinical usage applications toward more regular and first touchpoint use of cases. During the outbreak, as we saw, telemedicine even helped provide mental health support. See from the example of the North Carolina Health and Social Services, usage of digital solutions, especially for psychiatry, increased by 70%, and general medicine by 61% comparing to the same periods of the last year. The findings are significant because behavioral health providers have historically cited concerns that the virtual therapy could not be as effective as in-person visits, despite literature suggesting those fears are unwarranted. As a result, now we see that such providers lagged even further behind primary care and other psychiatric health providers and in adoption of telehealth prior to the telemedicine. Many outpatient services were closed entirely, either due to capacity issues or safety concerns, while intense social distancing measures made routine trips to hospitals and pharmacies an extraordinary task. Moreover, people with chronic health conditions such as hypertension, cardiovascular diseases, and diabetes are also those with greater risk of feeling critically ill or facing fatal consequences. For these reasons, many patients and their families even hesitated to visit a hospital. And you can see here on the slide how the number of digital meetings has dramatically increased during the pandemic period in Västerbotten region. The health authorities recognized this problem, and online consultation services were boosted either by revamping existing online telemedicine platforms or equipping public hospitals for such functions. The same changes were seen in the Russian Federation. For example, the number of the telemedicine consultations increased almost twice in the Murmansk region. The distance cardiovascular system, traumatology, oncology, and neurology, the online consultations increased in Nenets Autonomous Oblast by 30%. And the telemedicine technology is now more often used for EKG, for example, in the Kom Republic, where we see a dramatic increase from 1,200 cases to 1,026 cases. What the assessment showed? The assessment showed that the technical foundation for the e-health solutions were widely available before the COVID-19 in the Nordic countries. This helped the medical staff to leverage and extend their e-health capabilities during the COVID-19 response. As for the Russian healthcare system, it's structured on the historically necessary model of in-person interactions between patients and their clinicians. Clinical workflows have largely been developed to support and reinforce a face-to-face model of care. Therefore, the usage of digital solutions was not so much used as in the Nordic countries. It was mainly related to the doctor-to-doctor contacts. What we see now is that a significant shift in types and services and solutions provided, especially video consultations, remote working and remote monitoring, and teletriage. It shows that enormous potential in the critical situation, and the interesting question is now how much it will be sustainable. Digital solutions were more used for older people that might be linked to the chronic diseases. Now we see it can be used for almost all age groups. The COVID-19 pandemic has put the spotlight on digital health tools like telehealth and remote monitoring, as healthcare providers had to quickly pivot to technology to take care of their patients. The main challenges what we are facing based on the outcome of the assessment is that, first of all, it's not surprised to see the funding and regulations at the top of this list. We know that before, reimbursement for e-health services was much lower than for the standard type of the service delivery. This was a problem to increase the share of the e-health, and regulations were not pushing the usage of these services. When the pandemic occurred, leaders experienced rapid progress and regulations were loosened and the reimbursement was increased. Now the question is how if it will stay after the pandemic, and it is not clear whatever the government and the private payers will maintain reimbursement after the pandemic subsidies, or whatever reimbursement will return to the previous levels. As the data became more painful and complex, there is a need for improved understanding of its use while ensuring security and privacy measures are robust and access to data is appropriately managed. With the expansion of the use of technology and typical safeguard loosened, as well as more personal individually data is available to combat COVID-19, widespread concerns about privacy and security are mounting. A clear and well-defined digital health strategy focused on transformation of care requires new governance structures and tools to support and incentivize progress towards a robust digital healthcare systems. So based on our assessments, the preliminary recommendations which we're going to do is that, as we think, the patients need to be included as a partners and informed about the health technologies with a focus on how to access and use of such technologies. And this can be must considered to support vulnerable populations. We think that to improve health literacy, knowledge about digital technologies to ensure access to health services for every citizen is important. We think that the healthcare workforce requires expertise and guidance to evaluate new technologies using process grounded in real-world evidence. And finally, the reimbursement models must be designed to support and enable the required changes to clinical workflows, competencies in managing digital models of the care. One thing is certain, the use of digital tools to support an effective public health response is relevant during the current COVID-19 outbreak, and in the future will become even more so. Digital health is emerging as a priority for many public and private healthcare systems as a way forward to drive value for every global citizen, to ensure healthcare is accessible and equitable and high performing. Fortunately, the world is a different place than it was in 1918, even all we are wearing a face masks while walking in the streets or sitting in the buildings. We have the technology to strengthen our healthcare system for our patients. It is time we put these tools into the practice. Thank you very much for your kind attention. This was briefly the outcomes and findings of our assessment. We're going to continue to work on it, and as it was mentioned, we will discuss this more closely at the steering committee meeting, and then we'll try to develop some future projects and activities based on the outcomes of our assessment. And now I would like to give the floor to Niklas Hosling for his, let's say, final comments and findings.
Thank you very much. Thank you very much, Sasa. First of all, thank you very much for allowing me to sum up what this afternoon has brought us. I think that many of the presentation has given a clear direction that we are walking a path where we are involving, more patient-centric healthcare and social care. We look at different ways of finding more collaboration between different healthcare situations for the people, where both healthcare data should be able to be shared, but also to be able to provide a better understanding of the patient needs. So it's very much patient-centric what I see. I think, Sasa, you made a very excellent summing up of the assessment that has been going on in the work that you are leading in the steering committee. And what I feel when I have listened to all the presentation during this afternoon is that I think all of us can almost sign up to the conclusions that you made. You have heard me speak earlier before today about entrepreneurship, and you have heard my colleagues, Andreas Lundqvist, my head of unit for Center for Rural Medicine, and Bengt Andersson, my collaborative partner in the work that I'm doing with healthcare and care through distance planning solutions. And when I hear what you're saying and the direction that you're aiming to walk now, and that you all stress in your presentation, I think that we are on a track where we will see that patient-centric care will be the future. And also, as many of the presenters has underlined, that patient-centric care is actually integrated healthcare and social care. It's to center the healthcare and social care services around the patient. And this is critical to actually improve the opportunities for the patients to involve themselves in their own health and well-being, but also to become more proactive, to allow patients to stay healthy rather than to treat patients when being reactive. So it's more of this proactive approach that I see we all walk towards. I think that the Russian presentation gave us a lot of interesting framing of this, and how you could involve all the different components that we all work with, and that you also included the thinking of how we could actually transfer data, but also using different variables that are on our wrist or wherever they are, to actually be recognized as healthcare data that could be used to provide a better understanding of the different health conditions that people are currently living with. And information is key to actually improve the healthcare services. And I think that when information is becoming clear to the patients, as many of you have underlined, and also the entrepreneurs before lunch exemplified, that when healthcare situation for a patient becomes more clear, it's easier for them to understand what to do. And if they understand what to do and how to act, then we will see people that are feeling better and becoming more well over time. I'm very confident that this type of collaboration and this type of information exchange that we've had today are crucial to understand what to do next and how we could collaborate and do more of this kind of intervention that we have been exemplified with from so many regions this afternoon. And of course, some of our leaders have used different type of system for a longer period of time. But the experience from that journey that, for instance, Finland has had from electronic medical records to Kanta, and now to include more and more services through Kanta, and in a short period of time also having social services being included into Kanta, is a way that many of us will walk. And this type of understanding of the bottlenecks and the challenges that Finland has met during their path is crucial to actually speed up and accelerate the development in other regions that have taken part this afternoon. So I don't think that I will keep up the time that much more. I think that the intervention by all of you have been excellent. And again, the summary that you made, Sasa, from the assessment that has been sent out to all the regions within the Barents cooperation was very good. And I think that the steering committee will get back to work and to look at the conclusions made and see what type of next steps are crucial for this collaboration to take when it comes to digital e-health in the Barents region. So thank you very much for allowing me to sum up the discussion this afternoon. And I give the word back to you, Sasa, for the question and answer session.
Yep, thank you very much, Nicholas. Thank you, very nice. And first of all, thank you for all your support during this assessment and in the work of the steering committee. I think that is very nice that we have like a good team there and good understanding where what we're looking for. And I'm looking for the better and even more closer cooperation in the next year. So thanks a lot for all the support. And now I have questions and answer session to all the panelists. And the first question which came to our chat box was that, and this is the question to all the panelists, how the e-health development may be accompanied by increasing protection of the personal data. So who would like to start? Nikla, Jarmo, maybe you?
Okay, thank you. Thank you for opening this question. I would like to see here also engineers and cybersecurity specialists answering. But as a medical doctor, I see that it's crucial that we protect the health data because health data is very sensitive. It's our most personal data that we have. And while we are building these type of systems, we must ensure that all the communication channels and also all the applications, they are secure enough. And we shouldn't use that type of tools that are not specified for healthcare usage. Of course, it's very easy to use the ordinary social media tools, but then you always have the possibility to leak the information to outsiders. So security first, stick to those applications that are certified.
Thank you. Bengt or Nicholas, what do you think?
Yes, Bengt, maybe you can start.
Yeah, I think as Nicholas said earlier today, we want to get it back to see using, for example, GDPR to see that it's about what the citizens needs. I think when it comes to asking the citizens in a country, they think that all our organizations and our staff have all the data about them concerning their illnesses and diseases, but we have problems in doing this, and I think we should turn it on the other side and look at that as Nicholas said, with GDPR is a force we should use to really to get on the path that we need to do this.
Yeah, exactly. I mean, at least GDPR is a legislation that is covered by for the Europeans, that should be said.
Yeah.
But if we are not doing this, if we don't include the healthcare data, even if it's, I do understand and I hear what Jarmo is saying, and I fully agree that it should be certified equipment that we are using, so it's approved from the healthcare providers. But if we are not taking into account the data that has been generated from healthcare equipment that are certified when making any healthcare decision, have actually made the best decision for the citizens? That's the question.
No.
So if we are not being able to provide it, then we haven't actually done our task and our job as we should do. So this is the true challenge. How should we do this? But I can only stress that what I hear this afternoon is many of you are underlining this. It's on the agenda for all regions that have been presenting this afternoon. So it will be interesting to see what the future can bring.
Thank you. Sture, any inputs from your side?
Yes, I also agree with what's been said previously. We must remember that the confidence that the public has in the healthcare system is based on the trust and how secure we deal with information. And if we lose this trust, we are in big trouble. So we just have to think data protection and privacy to be built into the application from the beginning, and not something that we do afterwards. And just see that we do this in a good way. This is not one thing or the other, but data protection and privacy is utterly important. But at the same time, we should also mention that if this is too cumbersome, too much trouble, people take backdoors and do things that they shouldn't do. So it should be both simple and secure.
Thank you. Agree. Inga Vladimirovna, because you have mentioned that you are using this digital monitoring of the patients for the COVID-19, and then it comes this issue of the data protection. So how you have dealt with that in the Murmansk?
Ну, для нас охрана личных данных — это тоже весьма актуальная проблема, да, то есть у нас в любом случае это обеспечивается личными доступами и личными кодами доступа для каждого пациента, да, то есть и связано с личными кабинетами пациента, да. Поэтому только вот таким образом, да, мы можем обеспечить, когда есть четкая идентификация пациента и есть личные коды доступа, только такой способ пока у нас используется.
Большое спасибо. Yes, because my next question is that because we all remember that before the COVID-19, there was somehow still the resistance from the medical doctors to use the digital solutions more often because they were still preferring the face-to-face contact. So what do you see? How it's going to be changed after during the COVID or after the COVID-19 period? What do you think? Will be our doctors more willing to use these digital technologies, or we are going back to the old times that the face-and-face contact will be much more appreciated? So what was your experience during this COVID period?
So may I start as a medical doctor? So once again, I think that we have learned a lot during the COVID-19 epidemic, and we are not going back to the similar situation as it was before. We have learned to use, as medical doctors, the new tools, and those of us who are not trusting the digital communications and who thought that it won't work, we have seen in practice that in many cases it's doable. First of all, it's not perhaps too complicated as they thought, and it suits to a certain population of patients. We are, after the COVID epidemic, we are not using the distance communication as much as we are using the epidemic, but we are using it as a part of our toolbox, should I say, that there are various indications where you can use it, and then there are some areas where it's better to have a face-to-face communication.
Thank you. Nicholas?
Yeah, I can only, again, agree with what Jarmo was mentioning before, but I also think that there are two things that we should remember here. First, that now we have patients that have become used to have that service option. And maybe the drive for more distance banding solution will come from the patient side. So it will be a kind of requirement for the healthcare providers to provide different type of service alternatives. But I also think that a key point here is that what I've seen is that it has been the healthcare providers that have been able to, in a very short time span, to change their service models, which many of the healthcare workers a year ago would think was impossible. And they have actually managed to do this, and they've done it so great. And the third thing that I want to stress in this is that, okay, we have seen that the use of these services has gone down when the pandemic is not that, hitting us that hard, and now it's going up again. But maybe this is just a way of demonstrating that if we make it clear that there is an option for the healthcare users, then maybe we'll see an increased demand and use for it in future, because it hasn't been optional before. Sure. So if we make it seen as an option, then we will increase the use. And I think if we are sitting here as public bodies, many of us, representing healthcare system and social care system, I think if we would ask a private healthcare provider that are born digital, in Sweden we have many examples, Dr.24, Kry, etc., maybe they would have a totally different answer to this question.
Thank you. Thank you very much. Katarzyna, what is your, experience during this period?
Well, I agree with Niklas. This is an option that patients have now, to have a possibility to use digital services more frequently. And I don't actually see it going back to as it was a year ago. I think this is going to for healthcare workers and healthcare, we need to increase our services, and we need to actually listen to the patients and for their demands. But actually, when we talk to the citizens in our municipalities, sometimes they want both to have an option. Sometimes it's very convenient to have it, make it possible to book a digital online meeting. But sometimes they also want to face actually a real person. So I think this is very important to also remember that we are not alike. We are all different, and to actually remember the needs of our each and every person is important, even though the digital way will be the one preferred, I think.
Thank you. Sture, any inputs from your side?
Yeah, when it comes to resistance to digital solutions, well, I think we should bear in mind that not all areas is suitable for doing over, for example, video. There is a lot of some patients need to have some tests taken, or need some radiology or other medical equipment to check them up, and that kind of system isn't available on all the remote places. But there is sure a lot of that could be done, and we're not going back to the old situation. And I also think that the resistance has gone down. What I often hear from the clinicians is that they need support, and need close support. They don't want to spend time troubling with some technical difficulties or something. The schedule is too tight to do that kind of thing. So we need to also understand that it is not, the resistance is several things. They also need the support and be trust. They need to find their own trust in the system and find out what kind of patient they can use it for, and who they should not use it for.
Thank you. Thank you very much. Then before giving the floor to the governor, I would like to ask you, each of you, 1 minute or 2 minutes, just to briefly tell me how you see the future of the digital 2021. So let me start with Jarmo. Yeah.
I see the future very bright. The digital services are here. They are here at the moment, and they are here for the next coming years. And we are improving the care, and we are improving the connectivity between the care providers, and we are improving the connectivity between the citizens, as it was emphasized here many times, between the citizens and also together with the healthcare providers.
Thank you, Jarmo. Katarzyna, what will be your final words?
I think this is a great possibility for the sparsely populated areas, because with the digital technology and digital services, it makes it also possible for people to live and visit foreign places that are sparsely populated. So I think I'm very much looking forward to the future, and with a lot of digital services included.
Good, thank you. Bengt and Nicholas.
Yes, I think it's crucial to continue this development, especially for the sparsely populated areas. I think the map both you and I showed with the red spots. Yeah, I think that will continue, and we really have to work with our welfare model with digital solutions in sparsely populated areas. Otherwise, we will have problems. This is the base for regional development. We have to have a welfare in place. Otherwise, it will be difficult to other kinds of regional development in these areas as well.
Thanks a lot. Sture?
Yeah, I mean, 2021 isn't so long time until we arrive there. But what I see in the short term is a more patient-oriented healthcare, and a more we have more patient-centered health teams. I mean, a lot of the remote consultations today is one clinician to one patient, but there's a large group of patients that need a much more interdisciplinary approach, and where we have teams both from the hospitals and the municipalities that can work together. So this is what I hope to see, maybe 21, but at least in 2022.
Thanks a lot. Инга Владимировна, как вы думаете, 2021 год? Инга Владимировна, как вы насчет 2021?
Ну, 20-21 год, 21-22 год и далее, да, это только надежда на то, что мы, учитывая эти темпы, с которыми мы стараемся работать и решать все те же, у нас совершенно одинаковые цели и задачи, да, то есть, которые мы обсуждали, это сделать вот ту модель нашу взаимодействия с пациентом, которая бы, с одной стороны, не исключила личного контакта, да, то есть и позволила вовремя поставить диагноз, но при этом помочь пациенту сориентироваться в определенных профилактических, да, то есть позициях, то есть понять, как наблюдать за состоянием своего здоровья, да, то есть когда и где получить эту медицинскую помощь. Конечно, мы когда развиваемся, мы тоже думаем, почему и вопрос-то был для нас такой очень актуальный, защита информации. У нас это небольшой стопор развития телемедицинских консультаций врач-пациент, потому что у нас еще не доработан этот компонент, да, то есть когда мы будем идентифицировать пациента, да, как мы будем вести с ним диалог. Поэтому да, мы должны работать для пациента, а пациент должен нам доверять. Вот это как бы задача на следующие годы, и информационные технологии – это инструмент.
Спасибо большое. Thank you very much. And I see Andreas also with us. So Andreas, the floor is yours.
Yes, sure. I just wanted to say I agree with the previous speakers. I also look with enthusiasm at 2021 and the development that lies ahead of us. And I just wanted to add that I think that we know from previous research that solutions and technical solutions that has been developed in more rural areas can very much be applied in more urban areas, but not the other way around. It can be quite hard to take a solution that has been developed in urban areas and try and apply that in rural areas. So I think and I hope that a lot of the development for the future can be done from a rural perspective, so that we can have a place in that development in the future too.
Thank you, Andreas. Thank you. And from my side, just to say that You know, when we decided in 2018 to start to talk about development of this new program, the whole idea was that how to improve the healthcare system even in the rural areas and especially populated. And I think we will still keep this the main idea within our program. It was just that the COVID brought the totally new light on the digital solutions, and now we have even more attention. So I think that's very good for our program. But I agree with you that still I think our focus needs to be how to improve the healthcare system as a whole for those sparsely populated areas, because to make it for the people living there much better and giving them opportunity to stay and live longer and have a healthy life. So as for the 2029, I'm also thinking that there will be a lot of more developments in this in e-health, and I'm very glad that we have this program and we have this opportunity to continue exchange of our experiences and the knowledge, and looking forward that we'll have some good projects implemented in 2021. And thanks a lot for all the panelists for this very good and very interesting presentations. And now at the end of this our session, I would like to give floor for the closing of the conference, Ms. Helena Helma Knudsen, Governor of Västerbotten, who was with us during the whole second session and listening to our presentations. And Governor, the floor is yours.
Thank you, Dr. Tseritelli. And thank you all the panelists for a very interesting discussion and presentations. And I think it's clear from the speakers of today that e-health is increasingly self-evident as a means of making our health systems more patient-centered. E-health will help to empower patients to take control of their health and reach us out to communities in sparsely populated areas. It also supports health professionals and institutions to be more effective and efficient, and thus help us to balance the shortages of healthcare resources. But also how we can use data to increase both innovation and new research, and how we can collaborate between public sector in healthcare sector and patients, academia, and companies. Many speakers of today have touched upon the COVID-19 crisis, and it's demonstrating that the potential of e-health to manage some of our greatest public health challenges. As many of you have said, the future of e-health looks bright, and it looks even brighter when listening to the young, ambitious entrepreneurs today. And I think it's also important that we have to find solutions of the challenges that was addressed by the working group of the indigenous people. That is also one of the things that we could take with us when we develop this area in the future. I feel confident that the cooperation on e-health will continue under the Barents program of new technology and methods in healthcare in sparsely populated areas. Today, a lot of important topics for coming projects and collaboration has been presented, and I'm looking forward to follow you in your work the coming years. Now, I would like to close today's conference, and thank you to the moderators, Mrs. Johansson and Dr. Tseritelli, for taking us through the day, and thank you all the speakers and those of you out there following us online. I hope you have a good day, and when the times come, happy holidays, even though we are to celebrate this year a bit differently than we are used to. So take care, bye-bye.
And thank you very much, Governor. Thank you for your kind words. And I have one request to all the panelists or people who, if you can put your video on, because we don't have the physical meetings, but we can have a, let's say, like a family photos, if it's possible, so everybody puts the video on. One more, I'll try. Good. Thank you very much, and Merry Christmas, and as most important, stay healthy.
Thank you very much, Sasa.
Thank
Bye-bye.
you.
Bye-bye.
Thank you. Bye-bye.
Bye.
Thank you very much.
Thank you,
Bye
bye.
bye.